We go to the next presentation, which will be again a double presentation with the European and US perspective. First, Levi down. We'll discuss when we should release women from screening.
Thank you for that introduction, and I want to thank the organizers for inviting me to talk about our work looking at exiting women from cervical cancer screening, the United States perspective. So just to give you a framework, I'm going to present this as it was reviewed by the working group that addressed this question in the most recent cervical cancer screening guidelines published in March of this year by the American Cancer Society and joint groups. So the recommendation that we made was women over the age of 65 with evidence of adequate negative prior screening and no history of CIN2+ in the past 20 years should not receive further screening. So in summary, this recommendation is based on the fact that the prevalence of CIN2 is low in this group, as well as the fact that the rate of cancer is relatively rare. We, as other working groups, as you've heard earlier in the morning, made this recommendation based on the balance of harms and potential benefits. And then interestingly, some data from Dr. Schiffman and others suggesting that most new HPV infections in this group should clear spontaneously and have a natural history that's similar to women at younger ages. So this balance of the harms and benefits, which we based our answers to our key questions on, was relatively challenging for this particular question because, as many of you know, the data in this area is limited. So we defined our benefits similar to other groups and harms as you've seen in other groups as well. It's important to point out that we did not identify a way to measure or compare quantitatively anxiety or inconvenience, so this was just assumed to be associated and related to the performance of unnecessary colposcopy. Bottom line though, from what I'm going to present to you, that the quality of the evidence from our recommendations is moderate to low. In fact, when we looked at studies that specifically addressed our question of the harms versus benefits of stopping screening at age 65 or age 70, we only found one modeling study that helped us to address that question. The others were relatively small single institution studies that were just retrospective reports. I want to go over some definition of terms that we use. So first, I think it's important to understand the history of the phrase adequate negative prior screening. So in prior guidelines in the United States, there has been consensus around the benefit of 3 consecutive negative cytology results. So dating back to the early 80s and the guidelines by the American Cancer Society, 2 consecutive negative cytology results were felt to be sufficient to indicate patients that were at low enough risk to be exited from screening. Since 1987 and in past task force guidelines, that's been changed to 3, and I'll show you some data on that. We've also added in this guideline that 2 negative HPV tests 3 years apart within the past 10 years also defines those patients that have a low enough risk to be exited from screening. And I think that that concept is important when we think about the question of when to exit. So particularly in the United States, whereas Dr. Colossingham described, there is a large concern about the harms that might be associated with not screening, and our payers and patients feel at times that they might be having their health compromised by stopping screening. I think it's important to recognize that this is the phrase, that's the key phrase in the work that we did. We are trying to identify those patients for which it is safe to exit from screening. Obviously, when this criteria is not reached, then screening should continue. So the low efficiency of cytologic screening in women over the age of 65, this is based on a study that was published in 1995 in Sweden and was referenced in the original 2002 guidelines. For patients in this trial who received opportunistic screening, the peak efficiency, if you will, of 200 to 300 cases per 1,000 women occurred between the ages of 20 and 35 to 40. Once you began to look at women over the age of 50 and the age of 65 particularly, there was a dramatic drop in the efficiency of screening, with cases existing at less than 100 per 1,000 women. When you get out to age 70 and 80, that's dropping dramatically down below 25. Also in this, the original guidelines in 2002, the basis of the 3 negative cytology results was also based on the fact that the majority of the cancers in this population occur in an unscreened group of women. more recent data to support that from Kaiser of Northern California, where they looked at the reasons or prior Pap tests in patients recently diagnosed with cervical cancer of about 900 women. They found that failure to screen or failure to follow up on the first abnormal Pap test, so widely the majority of women diagnosed, were diagnosed because of poor participation in or unscreening. With regards to the recommendation for 2 negative HPV Pap tests, this study was published recently that looked at the Costa Rica cohort. Women were followed for approximately 16 years after baseline negative HPV test. They were able to define that there was a very low risk of CIN2+ in this population, and that this difference appeared to be not based upon the patient's age. So then getting back to our recommendation, so this is where I described that we were looking at the balance of harms and benefits. There is only one paper that modeled this question, and we found no others that actually helped us to address it. Dr. Colossingham in her report described that continuing to screen even to age 90 at 3 or 5 year intervals prevents only 1.6 cases of cancer and 0.5 cancer deaths per 1,000 women, extends the life of women by approximately less than 1 day per woman. But as far as harms go, we have 58 unnecessary or extra false positive cytology results, 127 additional colposcopies, and an extra 13 cases of treatments for CIN2-3 that were not necessary. The next question should be then, why age 65? So I'm showing you prior guidelines in the United States. You can see that there was some discordance around the age of 65 and 70. It was the belief of our working group that we would not find data to help us answer that question, but we felt that it was our responsibility to offer a little bit more guidance to clinicians in the United States. And I will tell you that we arbitrarily picked the age of 65, particularly in Dr. Colossingham's paper. We see some minor benefit by extending to 70, but because the number 65 was used more often in prior guidelines, we went with 65. Our next question is what to do about the risk of newly acquired HPV infections. I'm going to go back to the study that I mentioned earlier. This is a study of 10,000 women in the Costa Rica cohort, followed for up to 7 years of follow-up, in which they described that the newly acquired infections associated with a low risk of CIN2. And if we look at the 3-year risk of CIN2 for women under the age of 35 and compare that to older women, which you see on this table, this is the 3-year risk of CIN2+. You see that the very low risk in women over the age of 34 and specifically over the age of 42 is not that different from younger women. So we should expect that the natural history of new infection is similar, particularly when you consider, in contrast to what Dr. Moskiki showed you at her first lecture earlier, with a smaller cervix, less exposure to transformation zone or squamous metaplasia as we expect in the older woman, this rate may even be lower. With regards to hysterectomy, we took this question specifically to address whether or not there's a benefit to screening for vaginal cancer. Because the risk of vaginal cancer is so low, we do not recommend continuing to screen, particularly in women who have had surgery for benign reasons, no prior history of CIN2, and no pathology found at the time of their surgery. More specific studies that have addressed this question, looking at women who have had hysterectomy and cytology performed afterwards, the positive predictive value of detecting vaginal cancer is very low. And in cross-sectional studies of 5,000 women who have had Pap tests performed after hysterectomy for benign indications, there's only 1 dysplasia found and no cancers detected. So to summarize, our guidelines in the first column here are now consistent across the American Cancer Society, ASCCP, Society for Clinical Pathology, and the task force. And just last month, the American College of Obstetrics and Gynecology published their recommendations, which are similar to what we have listed here. Thank you.
Okay, Chris Meijer, may I ask you to present your European viewpoint? Chris Meijer is a pathologist from the Netherlands who has been pivotal in bringing HPV-based screening on the table of decision makers in the Netherlands, but also in Europe.
I have a little bit to excuse myself because I interpreted your question a little bit different. I will say what we are doing in the Netherlands. What you see here is the screening and the incidence from cervical cancer, and what you actually see is that the incidence of cervical cancer is in the western side of Europe quite good, but if you look to the Baltic countries and the east side, it's much higher. And the same, if you look to the mortality, then you see that the eastern parts and the Baltic parts are quite big, whereas in the other areas it's much less. So there is a lot of heterogeneity. Now, you all heard today there were two types of cervical screening: organized screening, which is called a Rico system, and you see Denmark, Finland, Hungary, Slovenia, Sweden, UK, and the Netherlands. They have already a more or less well-organized screening system, whereas there's opportunistic screening, which is, of course, already pointed out quite heavily in the other countries. Important part is that only 22% of the 190 million women targeted for screening in Europe have access to organized cervical screening. So, cervical screening is a very heterogeneous result, not consequently following EU guideline. The effect of joining the European Union by 10 countries, the Baltic, Poland, Bulgaria, Romania, resulted in more heterogeneity in outcome. And the effect of nationwide program screening has of optimal effect on cost and outcome. The cheapest program are nationwide, organized with Rico, widespread opportunistic screening programs in Western Europe, Belgium, Germany, France, Spain, Italy, Portugal, Luxembourg, 3 to 4 times more expensive. And there's loss of money in poorly spread organized program. And really in Poland, Bulgaria, Romania, the Baltic countries, there should be done a lot before we can go further on. Why is cervical screening for cervical cancer prevention insufficient in Eastern Europe and the Baltic countries? Because there's lack of organizational structure, there is no or limited resources available by the government, there's resistance of the physicians to change something because the invitation of the same women you have in the private practice, and there's insufficient public information. So in these eastern countries, in the Baltic countries, it's poor. There is now more and more awareness in the public, in the women, but it's still difficult. Then the question is the shortcomings in cervical screening programs in the EU, insufficient organization and control of the whole screening chain. And that's important because from invitation to the test results, to the follow-up and to the treatment, in that whole chain you should have the women under control, because otherwise you have lost to follow up and it will not work. And another important point is the low attendancy. And the low attendancy is really a problem because it's not more than 30%. There's poor test performance or no poor quality of cytology, so that's also an important point for the shortcomings. And there's insufficient follow-up of positive test results. Women are lost before treatment. So, which women do not participate? Is it young women, women not from Western origin, women from lower social classes, or women from large cities? How to improve the attendancy? Improve and optimize the organizational structure, and especially in the eastern countries where there is not a good organizational structure, it's difficult. Re-invite non-responding women, also very important. Involve physician in the invitation. Also important, better public information, and what is new development, and personally I believe heavily in the new techniques, is offer HPV self-sampling. Why is the attendancy important? If you look to the Netherlands, we have quite a reasonable screening program, then what you see here is that 65% of the people are screened, 10% have opportunistic screening and 25% not. And even in the other countries, you have similar results. At best, up to 70% of women are protected by programmed and opportunistic screening. About 30% is not screened. And interestingly, most of the carcinomas, or half of the carcinomas, is found in the 30% who are not screened. So the question is, can we do better? Yes, by HPV self-sampling. And you see here the whole procedure, how you can do it. We send an information letter 2 weeks later for opt-out. 2 weeks later, they get the device by mail, or they can collect it by the doctor. Women take the cervical sample and put it in a vial. Women send the vial by the mail to the lab or for HPV testing. HPV test result sent to women to the physician, and then only HPV positive women called in for triage by physician taken smear. And that's the disadvantage at the moment, because to triage them, they have to have a triage smear by the physician. And these women don't like to come to the doctor, so there's a problem. And the HPV positive women with a negative smear, they get a repeat smear, repeat HPV test and a smear after 1 year. What is the response rate? And this is very optimistic. Offering HPV self-sampling to non-responders, it results in 30%, and even higher percentages were given by Wikström et al. 2 studies only reported lower responses, Swarovski and Giorgi Rossi, and the response to recall letter is at best 14%. So self-sampling works. So implementation of HPV self-sampling increases attendancy, gives a higher sensitivity for CN2+, with lower specificity as cytology on a physician-taken smear. And more important, it has similar sensitivity, and that's a recent review which was made, similar sensitivity for CN2+ as HPV test on a physician-taken smear, provided the combination of self-sampling for the self-sampler and the HPV test are clinically validated. And that means not only validated on the HPV level, but on the level how many CN2+ lesions do you detect. Which women are reached or targeted by HPV self-sampling, and that's interesting. It is underscreened and never screened women. And that's independent of ethnicity, and they have the highest risk for CN2+. The time does not permit me to show this, but the interesting part is here, that if you look for the results, then here you see women who have not had a smear 7 years before. So these are the women who have or had a smear in the past 7 years. Here you see the women who have a smear at more than 7 years, and interesting, these are the underscreened women. And what you see actually is here that they have the highest risk. And if you look for the publication, then you will see that these women who are not screened, they respond better than the poorly screened or the underscreened women. So this is very important. HPV self-sampling detects or targets the women with the highest risk, and the women react on that. So the problem which you have is in HPV self-sampling is that if you would like to triage them, you should normally do that with cytology or cytology in HPV 16 genotyping, and then follow, and you would like to see how this works. But the problem is you cannot do this on the sample because the self-sample have low sensitivity. Cytology is not good working there. So the question is, if you have to send these women to the doctor, then you have a problem here for the physician. There's a significant loss to follow up. So there's need for a molecular triage marker directly applicable for HPV positive self-sampling. There are 2 molecular ways at the moment where you have quite interesting results for the future. This is the promoter methylation analysis of tumor suppressor genes involved in cervical carcinogenesis, and the methylation of HPV genotype genomes. And I think Nico Wensensen will talk to that later, but this is the other interesting development. And just to show you here you see what happens if you look for the methylation analysis of 2 tumor suppressor genes, CAT-M1 and M18, in cervical cells of scrapes as a triage tool for HPV positive women. And what you see, these are data from the POBASCAN, where we looked in the leftover samples. This was the sensitivity and the specificity of cytology. And what you see here is HPV 16-18 genotyping in cytology, and you see, because the women were referred on the basis of cytology, that if you look in real time methylation specific PCR, then you see that it performed at least as good as what you have with cytology. So this looks very promising. So the conclusions which I had, because I focused more on a tendency than on exiting the women, is that only 22% of the women in Europe in the screening age have access to cervical screening, which is of course low. And I mean then with cervical screening in organized cervical screening. The results in cervical cancer prevention in the EU are very heterogeneous, and the best results in country with nationwide organized cervical screening. No organizational screening structure in Eastern Europe and the Baltic countries leads to high incidence and mortality of cervical cancer. A tendency in countries with organized screening does not exceed 70%, so the question is that should be improved, and one of the interesting points is exactly HPV self-sampling. And of course there's much work, especially in the Eastern country and the Baltic countries, but also in countries where you have the organized screening. It's very important that we do much work before we are there, that we really have it. Thank you very much.
Thank you.